All right, good afternoon, and welcome to our webinar, Create a Thriving Sleep Lab with EnsoSleep. My name is Rachel Bohr, and I'm the Senior Director of Marketing at EnsoData. Thank you for taking time out of your busy schedules to be with us today. Now I'd like to introduce Nick, Montana, and Andrea. Nick Orr is EnsoData's Regional Sales Manager, covering parts of the Midwest and Northeastern US, as well as Canada. Nick's previous experience in healthcare was at Epic, where he implemented surgical and anesthesia software all over the world. He was EnsoData's first sales hire, but also had his hands in project management, implementation, and customer success. Throughout his time at EnsoData, Nick has spoken with hundreds of sleep labs across the US and Canada and is passionate about learning new things and helping others overcome challenges. Andrea Ramberg has spent 15 years in sleep medicine, learning every component of polysomnography from clinical to administrative. She is double credentialed with her RPSGT and CCSH and holds a Master of Science in Industrial and Organizational Psychology. Andrea is EnsoData's clinical director, and she joined the team in 2020 because of her passion to bring sleep medicine into the future. Serving as the current president of the BRPT, Andrea's goal is to empower sleep technologists in new roles through the CCSH credential as sleep coaches, sleep educators, and sleep navigators. And Montana Greider is a biomedical engineer who has spent her entire career in healthcare software. She has a background in product support and implementations and is only a couple months away from graduating with her master's in public health biology from Johns Hopkins University. Montana is a customer success engineer at EnsoData and joined the team just over a year ago. Throughout this time, she has done everything from supporting existing customers and implementing new ones to writing code fixes and assisting in product development. She joined EnsoData because of her passion for what can be achieved when technology and public health overlap. And now I'm going to pass it to Nick to get the presentation started.
Thank you, Rachel. Before I get started, I'd like to do a quick poll. And it's going to be checking with the audience to figure out what some of the challenges your lab is focusing on today. I was just at a conference a couple weeks ago, and it seemed like a biggie was staffing shortages. Some people are having trouble with getting patients to show up. Others are having scoring backlogs. So if you're able to respond, we'll probably leave it open for maybe a minute or so, and then we'll continue onward. All right, we've got about half the folks have voted. We're getting close. All right, 15 more seconds. Get your votes in, everybody. All right, there's a couple of stragglers, but we're going to close it at the minute mark. 1, 2, all right. Interesting. So it looks like about half of folks, the number one issue right now is staffing. I'm a little surprised by the second one, but it lines up well with the presentation. Is going to be patient no-shows. Sounds like some groups are focusing on HSAT growth. Definitely notably is people aren't seeing an increasing scoring backlog. So thanks everyone for participating. That's a really good foundation for the presentation here. All right, let's get into it. So the current state of sleep. There's still a large number of people who remain undiagnosed and untreated. HST programs are growing. I know here at EnsoData, I think pre-COVID, about 40% of our studies processed were home sleep tests. That's switched. Now it's like 60%. As about 14% of people said on the webinar, patients are getting sicker that are coming into the lab. Healthier patients are getting home sleep testing, right? And there's still not enough sleep techs, doctors out there in the field. This might sound trite. There's a reason for that, right? This exact slide was actually from a presentation I gave back in 2019. Some of these trends still stand, and back when I first started at Enso and got into sleep, I would call on people and they'd say, Nick, I don't believe in home sleep testing, right? A lot of those sim sleep labs don't exist today. So this isn't meant to be doom and gloom, but this is part of this presentation is trying to get people to be creative, recognizing what's going on in the industry and getting ahead of the curve and adapting quickly to some of these changes because things are changing quick. All right, are we gonna go through and you're gonna end out after this 45 minutes or so and know how to completely change your lab? Maybe not, right? But a couple of things I wanna focus on. One, in-lab bed utilization. Two is home sleep testing. Three is what I call study latency. And that's gonna be simply getting a sleep study quickly or the speed at which it kind of goes through the process. There's gonna be some Q&A. We're going to stop 2 or 3 times throughout the presentation, and Montana and Andrea know a heck of a lot more than me, so they're going to be helping me out a lot with that part of the presentation. So I am sales here at EnsoData. We do a lot of things in the sales process, and especially for larger organizations, part of what we'll do is kind of mapping out or a projection on how kind of some of our tools will impact the lab. And one of the key metrics we look at is bed utilization. So this was non-scientific. I went through, looked at the last 10 organizations or so I did this analysis with, took the average. It probably ranged from 35% to 105%. How do you get 105? I don't know. But something that always stands out to me is how relatively low the bed utilization is. An obvious factor for that's going to be staffing shortages, right? There's going to be some things you can do to help with that, some things you can't. But this is an important number to recognize, be realistic with yourself, and to know so that you can figure out kind of what to focus on. Here's how I like to calculate it, right? It's simple. Take the number of in-lab studies, in this case it's 80, divide by that by the number of beds you have times the amount of days that you're open. I like to do this at first, 30.4 days, right? That's the average number of days in a month to kind of see what's totally possible, right? You can reel that back looking at number of beds that you have open, given your staffing constraints, number of days. And then by doing that, you can kind of highlight, right, how many patients could you be running given your current constraints. That's going to highlight, you know, no-shows, right, or scheduling things. So this is something, this form here, it's way bigger. We have this giant Excel spreadsheet. It's kind of fun, if complicated, to go through. It's a good exercise to kind of see what you can focus on at your lab. So no-shows. I'm happy, all right, I'm not happy that 30% of people said that they were struggling with this, but I'm happy because a lot of people I talk with say that no-shows isn't a problem. And someone I really respect, his name's Sean Gibson. He's owned, I think he owned a bunch of labs in the early aughts. Most recently, he was managing like 200 cardiologists down in Texas. I'm not sure what he's up to nowadays, but he wrote an interesting article and he said how ambulatory patients, no-show is about 25%. Sleep, it's somewhere between 37 and 40. So it's a big issue. Not everybody recognizes it. Recognizing it is the first step, right? So I want to get into and explore a little with you why some patients might be missing their appointments and what you can do about it and who maybe should be doing that. These are easy. Send some text message reminders, right? There's automated technology out there to help you with that. Everybody's making phone calls. I'm going to challenge you to think about who's making those phone calls. A lot of people have office staff, clerical workers, non-clinicians. I'm going to get into that when we talk about patient education. I feel strongly that sleep technologists are the best people to be doing some of this patient engagement. Home sleep testing is part of this, right? I have friends, they're not going to go in for a sleep study, right? They've got a young family, they work a lot. The only way they're going to get testing is home sleep testing, right? So having those kind of services to access those patients. Some people have no-show policies, some don't, right? But I was talking with a colleague of mine, her name's Jessica, she's out in Ohio. I was talking with her yesterday and I'm like, I'm giving this presentation tomorrow. I've never run a lab before, like what would you do, right? And she said, Nick, you need to track the patient. And I think two things she said that were kind of enlightening. One, she sends letters to patients when they're not responding. People get hundreds of emails, phone calls from random people trying to sell them insurance. She said sending letters physically goes a long way. Another thing that she's doing is actually engaging with the referring provider. So that might be a primary care physician, cardiologist. And what she says tends to happen is patient will call their PCP, getting a refill on their prescription, and then the office can say, hey, we referred you over to the sleep lab down the street. They've said they've been trying to contact you. Have you been getting those calls? Patients will begin to show up, right? So let's talk about patient education. Patients that don't have any questions, or put another way, patients who have all of their questions answered are going to be more likely to show up. I'm not here to say that physicians are scary, right? But sometimes when the patients kind of see their physician, they might be intimidated, not ask questions that they really have. But honestly, they're going to see the doctor for maybe 30 minutes, right? And so they're going to leave, go home, and there's going to be a whole litany of questions that they still have that are going unanswered. So my belief is that sleep technologists can answer all of the questions about that patient's upcoming sleep study. What to expect, what the room looks like, how to prepare, some of the implications of getting the sleep study, why they're doing it. Sleep techs know the most how to sleep out there. You guys are experts, right? And so I think you're well positioned to be advocates for patients. By advocating for patients, engaging with them ahead of the study is going to increase the likelihood they show up. And proof is in the numbers. This is not a hospital that uses EnsoData, but it was run by a gentleman named Stephen Finch. It was smack dab in the middle of COVID, introduced kind of some of these policies with having techs engaging with patients ahead of time. You can see the degree to which he cut the no-show rate. I'm going to begin to speed up here. I'm kind of taking a little long, but I think one thing to note before we move past no-show rates is kind of why sleep technologists might be incentivized to do this. Every organization is different, right? But I know that some people, if a patient doesn't show up at night, that's a lost shift, right? So if sleep technologists have a reason to make sure the patients are coming in, that helps, right? And I think, it helps build trust, right? One of our colleagues here, her name's Jess Moore. She's great. She's based out of West Virginia, works in the Southeast and the Midwest. She would actually have patients come in ahead of time, see the rooms, acquaint themselves with the technologists, the diagnostic space. More techs showed up, or more patients showed up, right? So all of this engagement with patients, this is a sales presentation. How does EnsoSleep fit in, right? A big part of it's the scoring efficiencies. These are numbers from our customers today. You can typically shave off somewhere between 59 and 67% of the time scoring. Maintain, if not exceed, the quality that you're having today, freeing up some of the already kind of the staff that are already spread thin to focus on some of these other aspects of helping the sleep lab run efficiently. Okay, this is super cheesy. Win, 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 win. Try to introduce these policies and these changes in a way that's optimistically helping the doctors, helping the techs, helping the labs, and helping the patients. There's a way to do it, right? And something I hope we can think about throughout the presentation. referrals. When I talk with groups, sometimes they don't have enough referrals. Sometimes they have a 3-month backlog for getting into scheduling, right? So every lab's going to be different. So I think thinking about where you're at in this journey is going to kind of help you figure out where you're going to prioritize and maybe focus for the next 3 to 6 months. So a question to ask is going to be, where do your patients come from? If you're in a hospital lab, are they only coming from physicians within the hospital? If you're a private practice, are they only coming from sleep doctors? Are you allowing for direct referrals from cardiologists and PCPs in your area? A lot of people have kind of rely on the network of referral providers that they've had for the last 5 or 10 years. So I'm kind of challenging folks to think about who's referring, how are they referring, and what can you maybe do a little bit differently to engage with other specialists in your community. So build new relationships, right? There's still, even though we have a lack of sleep doctors, a lack of physicians, there's only a 3% growth nationally, there's still new doctors entering the field, right? Build new relationships with those providers that I mentioned in your community. Focus on the people who are already referring to you. Ask them if you're doing a good job. Ask them what you could do better. If you take their feedback into account, make tweaks to your process, it's very well possible they could send you more patients, right? You can create collateral, fax things to PCPs, have technologists go, talk with them over lunch. There's a lot that you can do here. And again, who's probably the best poised to educate, in this case, providers in the community that your lab exists, does testing, takes care of their patients? It's going to be sleep techs, right? So this is another thing that I encourage people to do, depending on where they're at with the referral sources. Spend a little less time scoring sleep studies during the day, maybe spend some more time engaging with your referral providers to make sure that they're sending you patients. All right. This might be the most controversial topic, but I wanted to bring it up. It's something that I think is nuanced. People have pretty strong beliefs. It's worth a discussion. So let's get into it. Sleep labs are allowed to run a 3-to-1 ratio, having one technologist oversee 3 patients at night. Back a little bit, I mean, over 10 years ago at this point, the ASM actually wrote this explicitly into policy, and there was a huge pushback, right? Both from sleep techs, the physician community, sleep labs, and now the wording is somewhat ambiguous, right? I work with labs that do 3-to-1, score on the fly, 3-to-1, don't score on the fly, 2-to-1, score on the fly, right? A lot of labs do things very differently, right? And so I kind of want to recognize that. But something recognizing I'm not a clinician, I've never run a sleep study, I'm not an RPSGT, I kind of think back to my little brother who is a clinician, or he is a, right? And he's a nurse. His first job out of school was an ICU nurse in the middle of COVID. He was working on the East Coast, and he would be overseeing sometimes more than 6 patients at a time who are extremely sick. So I can't help but think, if he can do that, you know, we're running sleep studies and patients are getting sicker, so I want to be cognizant of that safety aspect. But I also want to encourage people to be creative, flexible, and maybe most crucially is engaging their staff to talk about some of these things that are going on and collaborating together to figure out how you can do things to help still see patients, right? I don't think you should do 5/8. I put this on here and I ran that by people and they almost like came after me with pitchforks. So don't do that, right? But I think in thinking about, are you doing 3/12s? Can you do 4/10s? Are there incentive structures that you can put in place if there's some flexibility there with their staff to kind of incentivize things, right? Incentivize the technologists to help you see more patients. And something I'll put in a plug is real-time scoring, right? It's maybe the thing that I'm most excited about here at EnsoData. It only works right now with Respironics G3. We're adding a second device. We've committed to do that this year. We don't know what it is yet. So the more people that want it for their devices, let us know, and that'll help us prioritize development. But I'll maybe let Andrea answer it if there are some questions about this. But in a sense, this is scoring in real time. It's going to be helping sleep technologists do a more accurate titration, showing a table with pressure and AHI over time, in which case it very well may manifest in having a scored report at the end of the shift, right? And the real goal in having this is to help sleep technologists titrate the patient properly at night, because I know it can be hard, right? All right. Maybe we're about halfway through. Hopefully I'm doing okay on time, but Rachel, Q&A?
Yeah, I think we're doing good. All right. I actually, before we do the questions, there were a couple of good comments that I just wanted to mention that some of our attendees put in the thread. One was, I incorporated a time every day that sleep patients would show up for educational purposes only and to see the lab. So that's fantastic. And then another attendee said, my lab gives an extra $50 for running a third patient, maybe something others want to consider implementing. So that's fantastic. All right, so the first question, how many units do most labs keep on hand on average? What are you hearing?
Ooh. Should I take that one? Do you want to do it, Andrea or Montana? It's going to depend on the size of the lab. I think like when I talk with home sleep tests, like equipment providers that do drop ship programs, they usually can have one study done every 9 days, right? But that's going to be shipping it to the patient, which adds time. So it's going to be dependent on your referral volume, how long it takes to get that study around. I've heard as long as 9 days. If patients are coming in, picking it up, that can be as short as 2 or 3. So I think the variables would be, how long does it take to turn around a study, and what is your referral volume for the HSTs? Average for a small labs, like 10 HST equipment, probably.
Okay, great. Andrea or Montana, do you guys have anything to add there? If not, we can move to the next question. Okay. I think this one might be more for Andrea, and it is regarding real-time scoring. How do you see real-time scoring changing the way technologists do things?
Yeah, I love that question. So as a clinician and as a technologist, I mean, the idea that, especially as we're first learning, or even as we're going through our careers, the idea that we can get extra added help for us at night as we're taking care of all these different patients, and we might be in with another patient, right? And the other patient has things going on. And so where I see it really benefiting clinicians is it's kind of an extra added tool set for us, right? The coolest thing is it'll ding when you hit the split night criteria. So for example, you input what your medical director put in for the split night, or maybe your policy and procedures that you already have. And with the scoring, it's automatically gonna calculate that for you. And you could always look back like 7 to 8 minutes prior to change whatever, right? If you don't agree with something. But it keeps track of that for you. So then you have an added benefit of, I think we've all sat there and looked at our patients like, do we split this patient? Do we not split this patient? Did they have enough events? So for me, I see that as being a huge advantage for technologists at night.
Great. All right, next question. This is from a customer. I already use EnsoSleep to score my PSGs. How do I get real-time scoring set up? Is it a different process? So maybe Montana, could you take that one?
Yeah, so for this, it's a bit of a different process. So depending on how you currently store your studies, if you store your studies on a shared drive, we will have to download the EnsoSleep application on each acquisition computer. But if you currently have EnsoSleep reading directly from your acquisition computers, essentially all we have to do is make an update to the app from our end, and then it's ready to start scoring in real time. There's obviously some training involved, familiarization, things like that. But as far as the actual install process, it's relatively simple.
Great, thank you. Let's see. Okay, one more, and then we'll move on. How can techs help more with referrals? So maybe give some examples. This sounds like an Andrea question.
Sure, yeah. I get really excited about this because I think who better to talk to the public, who better to talk to other allied medical health professionals than sleep clinicians? I mean, Nick pointed it out, the technologists are going to be the best at doing this, right? And why are we keeping them behind closed doors? I feel like our skill set is not being utilized fully. And that's where I get really excited about the new roles that are coming out for sleep technologists. For example, one of the roles that I've personally done is a sleep navigator. And my referrals increased 33% of the lab's volumes were from the hospital setting. And that's not even everybody coming in through there, right? Like there were no shows, just like we all talked about. So to me, that's a critical role that sleep technologists are just not filling at a broad base right now that we could really help with referrals into the sleep lab.
Great. All right, why don't we close out this Q&A session, and then we'll move on to the rest of the presentation. But just a reminder to get your questions in as we're going, and then we'll hit them up at the next Q&A. See you in a bit.
Is it my turn now? No. All right, let's talk home sleep testing. We could probably talk for like 4 hours about home sleep testing at a lab. So if anyone here on the webinar is going to a conference soon and wants to do that with me, I'm down for it. Logistics, turnaround time, cleaning it, referrals, different creative things you can do there. For the most part with the home sleep testing, I am going to focus on equipment. So I just wanted to recognize and call out that this is nuanced. There's a lot to consider with home sleep testing. I am going to focus on kind of the equipment itself. So for the most part, people have come to terms and recognized home sleep testing is an important testing modality in sleep medicine. There's still some naysayers, right? There's times when it is and isn't appropriate. Most have recognized that it's a reality. And so I think as people are thinking about, sometimes they've already done kind of an investment, capital expenditure, and have devices on hand, right? A lot of groups are thinking about, okay, what is my kind of profile of devices going to look like? What's my menu of services going to look like here moving forward? I think questions that I encourage people to ask are, who are those types of referring physicians? Depending if it's a PCP, cardiologist, or a sleep physician, that's going to dictate and impact what kind of tests they're going to want run on their patients. Is it sicker patients? Is it pediatric? Well, you can't really do HSTs on pediatrics. Well, some people do, but good questions to ask, right? Unfortunately, I mean, these next questions are harder to answer, right? But I think staying aware of, talking with people in the community about the degree to which they can get serviced, fixed, replaced, repaired is important as you consider your HSAT vendor. And considering your options. Do you have cash flow enough to buy devices outright? Do you need to rent? Some vendors or HSAT manufacturers offer both. Some just allow for buying. So I think answering those questions for yourself as well is important. And I mentioned, this is probably a little bit, everyone on this webinar probably knows this, but I'll say it quick. There's generally 4 types of devices from the ASM. Type 1 is going to be attended polysomnography. Type 2 is kind of what I call is unattended PSG. It's kind of exciting. There's some new devices out like Cerebra. Nox A1 has been out for a while, but kind of like a PSG in the home. And then type 3 devices are going to be kind of like the more traditional airflow-based devices. Great examples, Nox T3, ResMed, the Night One, Cadwell, Apnea Track Core, right? And then type 4 devices are kind of ones that don't fit that profile, right? And there's a lot of exciting devices coming into the market that fit that profile. WatchPat, Bidium, Sleep Image, the list goes on, right? And I'm not trying to be deferential here, but like there's a lot of cool devices out there. Check them out. So there's a lot of devices. There's type 4 devices. There's type 3 devices. I guess what I'll say before saying how we get in EnsoSleep can help is something I do see is where if sleep doctors have been in the field for a while, they're going to want airflow-based devices. Sentiment is changing, but they're going to be more comfortable with the waveform data that comes out of, say, a ResMed or a Philips study or CleveMed, right? Cardiologists tend to like WatchPat, right? PCPs, they're managing so many different comorbidities in their patient population. They just want a sleep study, right? So something that's fast, easy for a patient to use, maybe a more novel kind of signal, right? Sleep Image comes to mind, might be more appropriate. And I think what I'm finding, and my opinion changed over time, I used to think just have one device, right? It's going to simplify things. But now I've realized that, and the more people I talk with, most people have two, right? Some sort of type 4 device, some sort of type 3. Some people I talk with will have 4, 5 devices on hand, and figuring out when it's appropriate, when you're going to use that HST is important. All right, so home sleep testing. How can we help? First, I'm going to talk about there's a lot of HSTs, devices, how we can help with that. Second thing is kind of a cool analysis that we do on those type 3 devices. These are all the devices we work with today. It's a lot. I would love if people raise their hand if a device they use isn't on this list. But we pretty much anything in green, we can score with AI. Anything that's orange, we support in our study management platform. And so you're going to see on the HSAT side, most of the devices out there are going to be supported on our platform. And the idea for that is it gets tricky for a physician workflow, for example, to have 3 different reports, 3 different viewing systems that they use for home sleep testing. We help bring that into a single workflow. This thing's cool. If you haven't heard about this is pretty neat. So I'll go back to this table. Something that you see is in this type 3 portable HST. On the far right, saying, does it measure AHI or not, right? Technically, it estimates the AHI. And the reason for that is because generally these home sleep apnea testing devices can tell whether a patient is breathing. They historically haven't been able to tell if the patient is asleep or not. And so we developed a technology. It uses what's called PPG or photoplethysmography. It also looks at some of the other airflow signals in a type 3 device. And we can tell epoch by epoch, is the patient asleep or not? And there's kind of 3 implications of that. One, it's increasing the fidelity of the HST. It's getting closer to that AHI, right? Which you weren't able to get before with a type 3 device. Something that we've seen is take a look at the CPT codes, right? Medicare, like Max, about 1.5 years ago, started mapping G codes to CPT codes. A lot of 95806 or a lot of type 3 devices are billed at 95806. A requirement for 95800 is to have sleep time, right? We have an FDA cleared algorithm that gives sleep time. And so I think the third thing that's important is both in kind of our internal investigations, right? It's not published, but in the prevailing literature, there's an idea that the AHI tends to be underestimated with these type 3 devices. And that's because by definition, the sleep time is going to be less than the monitoring time, right? So it kind of, generally the AHI tends to uptick a little bit, and sometimes that impacts treatment, right? And it's accurate, high level of agreement. It's comparable to the EEG gold standard. And in the clinical trial that we ran in 2021, it was at least surprising to me. It might have been surprising for the team too, but we were very close to the PSG gold standard for the actual overall sleep time as well. All right, so home sleep testing, before we get into Q&A, there's a lot of devices out there. Check them out, read the FDA clearances, talk with your vendor, and I would definitely encourage you to probably have a type 3 and a type 4 device on hand, and it's definitely going to be impacted by who your referring providers are.
Thanks, Nick. Yeah, I was going to say we did have someone in the question panel asking for advice. So I think what you just said is perfect. You know,
cool.
As far as like checking with the different vendors, maybe ask for recommendation or references, that type of thing. All right. We do have a couple other questions. All right. The concept of a more clinically validated diagnostic outcome is something everyone in the sleep field is interested in. How do you think it influences treatment?
I'll take that one. On the sleep side of things, we know that, Nick covered it, that the reason why HSTs often show not the most diagnostically accurate AHI is because of the sleep. So adding this type of technology helps us better diagnose our patient population. And I have actually a personal story with that. I had an HST done and mine was negative, but I was still suffering, right? And then I finally go get an in-lab done, and sure enough, I did have something. So I often wondered, how many more patients or what patients are we missing out on getting treated by not having that more accurate diagnosis with that? And how much more patients maybe just say, okay, I have a negative HSAT, I don't need to follow up with my physician with that. So I think adding this technology with that just makes more sense to better take care of our patient population.
That's a great example. Does anyone in the audience have any other questions? We actually only had the 2 for this section, so just want to throw it out there in case anyone wants to get a last question in about this section before we move on to the next. All right, I'm not seeing anything, Nick, so why don't you keep going?
I was going to be like, is there anything not on this list that we should add to it? But all right. Study latency. It's kind of a highfalutin term, but I think of it as like, how fast is a sleep study moving through the process? And, when you think about who's ordering the sleep study, how it gets to the lab, who's doing something with that order, the test happening, what happens after the study's finished, who does that go to? There's a lot of steps in the process and a lot of people involved, right? So I think of like, how are you getting the order? How are you triaging and prioritizing studies? And how are you going to get that study result to the physician? And this is the portion where it's going to be pretty heavy Enso, right? But we created some really cool technology in our study management platform about a year or 2 ago. We finally realized how great it was and started marketing it. Thanks, Rachel. So I'm going to be talking a lot about that today. So, I mean, if I'm thinking about a typical sleep lab, right? You have one in-lab system, one HSAT type 3 system, and then you have a type 4 testing modality. And those tend to be 3 different workflows. You'll often have 3 different viewing systems, 3 different report generation workflows. That's going to be assigning patients in different systems. The different technologists are going to have to get used to how to score sleep studies in 3 different ways. The reports generated out of those systems are going to be 3 different looking reports with information in different places, right? Some systems you can't even configure the reports. And then not to mention at the end of it, if you're in a hospital, now you've got 3 different systems. You've got Cerner, Epic, or some other EMR, and you have 3 different ways of getting that back into the EMR, right? And so not only is that different workflows, but then you wind up as a sleep technologist clinician, you're not working with patients, you're not even doing scoring and analyzing of waveforms, you're like moving files around and doing data abstraction and making sure patient MRNs match up and trying to upload things into the right place, right? And that's neither fun nor is it efficient. So we've created a platform that kind of starts from after the study's completed through the interpretation that really unifies that workflow into a single space. This is what it looks like. It's pretty cool. Not to do like a cliffhanger, but we didn't bring someone on to give a demonstration, but it's pretty slick. So if you haven't seen that kind of study management workflow, I guess Rachel will get into like some of the next steps here, but it's pretty cool. So another piece, I mean, this is how we got started, is with the scoring. I don't want to belabor this because nobody mentioned on this webinar that they had a scoring backlog, right? If people do, that's one kind of small part in that process. Sometimes, especially with the staffing shortages, I have unfortunately met some groups recently. It was taking 1 week, 2 weeks, 3 weeks, 4, sometimes, or typically not more than that. But the scoring can help with that to make sure studies get through quickly. All right, I mentioned at the end, getting things back into the EMR. I used to work at Epic. My boss used to work at Cerner. I mean, we're in Madison, Wisconsin, right? The headquarters of Epic, so there's some natural overlap here. And something we put off for a long time was getting data back into the EMR, and the time has come. So, I mean, typically a physician who's referring, they're going to fax it, put an order into the EMR. That order gets sent over to the lab. Sometimes it's automatic, sometimes there's manual abstraction, right? And something that we've done at Enso is really being able to close that loop, get that information back into Epic, right? Sometimes it closes an order for billing, but I think more importantly, it makes that sleep study information available to other people that are part of that patient's care pathway. So there's a lot of different ways we can do this, right? There's FHIR, there's HL7, but generally I think of kind of 3 different ways to kind of close that loop, get this information back into the EMR. One, you can put in a finished report, right? So you can generate a report in our study management platform, push that back into the EMR. That's one thing. I think the second thing, and Rachel, thanks for bringing up kind of my anesthesia and surgery background. This is one of the things that I'm really excited about because I feel anyone who's worked trying to get changes approved in an EMR system knows that that's a whole kind of adventure. But imagine a world where we can put that specific AHI back into the EMR, percolate that up. Instead of doing a stopping preoperatively, you show that to the pre-op nurse, you show that to anesthesia. That impacts their preoperative note. They're using that to look at the Mellon-Potty score, and that's going to impact how they intubate the patient, right? So I think I'm really excited about moving those, as we move these discrete data from the sleep study into the EMR, the downstream clinical impacts there. And the third thing is some people don't want to do a note, right? Even in a cool looking website that ties everything together. So people can kind of take that note, pull that into an actual note in the EMR and do that workflow instead. And I don't know if anyone's from like, well, last thing we do, we have a published API. And API, I think of kind of as a lexicon, a translation tool, a dictionary. It's a way that software developers can kind of tap into our system, selectively pull data. We have more than a handful of groups now that actually have their own development team. There's some really neat things that you can do with this. But I will say consuming the API is a little bit technical and you do have to have developers to do that. So I think the biggest thing here is when you're thinking about study latency, trying to get studies through quickly, we've developed a tool that does that. One of the big ways is it unifies the workflow to make it a singular process. The last thing we did was to really tie the loop, getting that back to the places it needs to be, namely the EMR. And that way it kind of minimizes some of those, not even administrative, not even clerical, like IT steps that have to be done to take that sleep study data, get it back into the EMR. So before we kind of wrap up and get into Q&A, I don't know. If you did everything that I talked about, would you create a thriving sleep lab? I don't know. But I am hoping that kind of encouraging you to look at these key performance indicators, look at some of the numbers at your lab, look at what you can measure, recognizing it. It might not be as pretty as you want it to be, and seeing what you can do about it, right? What's maybe one thing that you can focus on the next 3 months? How can you collaborate and engage the different stakeholders, the techs, the physicians, the patients, the referring providers, the hospital, to help make decisions, because sleep's changing fast. What's your HST strategy going to be, right? If you're not setting up HSTs now, you've got to be, right? And I feel pretty confident in saying that. And I said the win-win-win thing, you know, it's important to engage everybody, the doctors, the techs, the patients in this decision-making process. So at the risk of continuing to talk more, I'm going to kind of pause and get into Q&A, and, you know, thanks for joining us today.
Thanks, Nick. All right. Okay, first question. Which EMR do you currently integrate with? Montana, do you mind taking that one?
Yeah, so this will be any EMR that accepts an HL7 feed. That's pretty much the standard across the healthcare industry. So that's the one we picked to start integrating with first. So that works with Epic, with Cerner, with AthenaNet, with a handful of others that we know sleep labs use.
Great, thank you. I think this one might also be for you, Montana. This is a current customer using study management, but there's some steps in the workflow that still feel like they're taking too much time. Do you have any tips for better usage?
If that were the case, I would contact your customer success BFF and have them take a look at your study management steps. There are some ways where you can configure the steps to automatically assign for certain users. So say you have a technologist who always reviews your HSTs, have that step set to auto assign to them so that no one has to go in and actually click. It's an automatic workflow. I would also encourage turning on email notifications, especially for physicians and people that aren't, in the software every single day. And then also, once we do get the HL7 interface up and running, that would definitely help streamline your workflow so you don't have to worry about downloading the PDFs and handling those.
All right, thank you. We have another HSAT question. If you use different HSATs, could this bring them all into one place?
Should we all give
absolutely
from everybody like that?
Yeah, we have many customers doing this, for streamlining both their HSTs and their PSGs. Like we have some customers who use 7 different units and they all feed through the system. They all have the same reporting. They all have the same workflow. So that keeps it really cohesive.
Fantastic. All right, we do have another question. I think this one will be for Andrea. How do you see having sleep study results available to all medical staff in the EHR influencing patient care?
Yeah, that's a great question. And Nick kind of hinted at it a little bit earlier, but especially from a clinician point of view, I would be taking care of patients in the hospital system and have no clue whether they had a history of a sleep study, no clue anything to do with their sleep history. And to me, I see such a huge correlation with how we're treating that patient in the inpatient setting, dependent on whether they've had that sleep study or what's going on with that. So I see having that discrete AHI in there a very quick way to get to the patient a lot faster and provide a lot of faster of a care plan for them. And I know we've all had it to where we go to one doctor's office, we have to fill out a health history, and then we go to another doctor's office and you feel like, why am I filling this health history out again? And I would hear a lot of patients on our side of things on the lab saying that they were just in the hospital, but the hospital's EMR does not talk to the outpatient lab or even the primary care EMR, right? And I see this really helping to facilitate that continuum of care to offer faster, more efficient care plans for our patients.
Thanks, Andrea. All right, it looks like we don't have any more. So if you do want to learn more about EnsoSleep, you can always email us at team@ensodata.com. Otherwise, there's lots of different ways that you can find out more on us and how to get connected with us on our website as well. And then just thanks again for joining us today. You know, we really appreciate your time. We know you are all so busy, and we're very grateful for the opportunity to support the important work that you're doing in sleep medicine.